I'm Doug Johnston. I'm the Chief of Cardiac Surgery at Northwestern Medicine and the Bloom Cardiovascular Institute. And I'm joined today by Dr. Paul Cremer.
Thank you, Doug. Good to be with you. So I'm the Director of Multi-modality Cardiac Imaging here at Northwestern Medicine.
So multimodality imaging is not necessarily something that is present at all institutions, and where we have an expert in the field who is directing that effort.
When I think about the strengths of multimodality imaging from a cardiac perspective, it's really making the imaging evaluations about the disease, about the patient, not about the specific modality. And that is why having a pericardial disease program is a really good example of the role of multimodality imaging. So recently, we took care of a young patient, late 20s, had been very active, and over the course of a year or two, just gradual fatigue, gradual swelling. And because he was such a good baseline, no one thought anything of it. So by the time he comes to see me in clinic, he's an overt right heart failure. His imaging, his echocardiogram, is classic for constrictive pathophysiology, and his MRI shows a lot of pericardial inflammation. And that, had been missed. We were able to get him on appropriate aggressive anti-inflammatory therapy, calm down that inflammation over the course of a few months, then went for radical pericardiectomy with you, and now is back to having a full and active lifestyle.
You did an advanced fellowship in cardiovascular imaging. Maybe talk a little bit about how that makes you think differently about reading CT, MRI, echo, nuclear, all as one person looking at the patient and reading these studies.
In general, I would say when you're trained in multimodality imaging, you have a better appreciation for what are the strengths and the weaknesses for every test. So if we're thinking about pericardial disease, the echo is really the best way to look at what's going on hemodynamically. Whereas the MRI, though we can get some insight into constriction, is really helpful for looking at the inflammation. And we primarily do that currently using late gadolinium enhancements. So we can look at the severity of that late gadolinium enhancement and have a good idea of how long this patient may need to be treated with anti-inflammatories. Whereas with CT scan is really best for looking at the degree of pericardial calcification and procedural planning, be it for pericardiectomy or sometimes for pericardiocentesis. So I think when you come to it as a multimodality imager, you realize really, okay, what is this test best at helping me with to answer the question, that's presented by the patient.
How do we think about that patient from a multimodality imaging standpoint, and what differentiates Northwestern in terms of our approach?
So the multimodality imaging really brings it to a disease-based focus. So a patient can come to our pericardial clinic, meet me in the morning, have all the testing, and then at the end of the day, we can go over everything and have an answer of what direction we should take with the care. So we can do all that in one day.
Well, thanks very much, Paul, for joining us. I think this is an area we're very interested in for future growth and development, and to be able to expand the quality care we deliver here to more patients in more places. Thanks very much to our audience for joining us today.